I want to begin by thanking the organizers for including me in the talk. And I want to point out to you, ICAN, that I was there when you were born. Okay? I went to medical school after a brief career as a public health nurse and research nurse, which involved obtaining some funding for what we were doing, and I was successful and went to medical school the next year. Life took me in different directions, and let's see. I ended up spending 12 years at the NIH in Washington, where I was the program director for pediatric critical care and rehabilitation research, and did considerable support and conferencing about policy in child abuse research. That eventually evolved into a branch of the government. I came home in 2013. I thought it was all done. You know, I didn't even call you. I ran on the beach. I played tennis. I had a great time. And then by accident, I became the court pediatrician. I'm double boarded in intensive care as well as in general pediatrics, and I've done a lot of research, published some papers, stuff like that. These are some disclaimers. No relevant financial relationships to disclose. If you want to give me some money, I'll take it and have a relevant financial relationship. I have no discussion of off-label or novel indications for drugs. When you give a talk in Washington, you have to start this way, okay? So, Dr. Durfee has been gathering data about PICU scan team relationships. And by scan, I do mean suspected child abuse and neglect. I didn't realize that wasn't lingo that you all throw around. I thought you did. What's that? Okay. So, so he's been doing that, and he's shared his data with me. And the whole 12 years I was at the NIH, about every year, couple of years, Mike would call me and tell me what was going on. So, why would such information from PICU hard data? Now I want you to step back and take a look at yourselves in terms of research. Why would that be important? Why would it even work? It will inform policy, it will generate hypotheses, it'll refine research questions. As I've been home in LA County, I find lots of people who want to do research talking to me, and I try to help people refine their research questions. Janice is laughing because I've been trying to do that with her. Attract formal support in terms of advocacy, and attract formal support that is financial. I administered a program of $40 million. There's billions of dollars to compete for. I don't see why you couldn't do it. You have the largest service in the country. It helps with program development and integration, most importantly, into permanent infrastructure to serve fragile, vulnerable children. What proportion of PICU, these are some tentative research questions. What proportion of PICU admissions in Los Angeles County represent pediatric trauma? What are the demographic variables that distinguish this pediatric trauma population from the demographic characteristics of the child population in Los Angeles County? These are questions I think you could be funded to answer. Does the pediatric critical trauma population have a higher rate of prior child welfare DCFS involvement than the overall child population? At the NIH, we talk about a phenotype concentrator. I believe that the PICU, probably the ED too, but the PICU is a phenotype concentrator. In other words, it's a funnel that moves these people, these subjects of research interest, these children who are so fragile and vulnerable, towards a gathering point in the PICU. I was the project scientist for a large collaborative pediatric critical care research network, which was 7 sites, 8 hospitals, included here in Los Angeles County. Guess what? Earth to you. CHLA and UCLA made a collaboration and applied to me, and I funded them. They collaborated. How about that? It was in a consortium with UCLA. The CHLA PIs were Kit Newth and Rick Harrison. Rick was the one who drove across town and had lunch, and I was the project scientist for this network all over the country. It was about 18,000 PICU admissions a year, about what it was about. I wanted to show you some hard data, so I used some of the data, you know. When they applied, I made people quantitate how much trauma they had. You couldn't even get to NIH peer review until you quantitated it in this way. Is there a pointer here? A light? That red thing? Okay. Yeah. Not today. Oh well. Anyway, what? It did for a minute. I don't squeeze it hard. Yeah, but it won't go. Yeah. Okay. Well. So the categories, in order to compete and even get your application not sent back unreviewed, you had to quantitate your PICU admissions, and I made them do it by race and age and other things so that I would have a network that represented America. I didn't want all of one ethnic group or another. But anyway, they had to say how much trauma they had. And if you'll see in this PICU, this is their first application in Children's Hospital Los Angeles, and you can see that their total number of admissions for a year was 1,155. It's not very much, okay, compared to the people they were competing with, and that 669, it was about 67%, were trauma. And I quantitated them in other ways, you can see, about oncology, different things that were important then. And they competed a second time, and I was able to fund them the second time. And by this time, there was, you know, a little 400 more PICU admissions, and 70% of them were trauma. So in those two time periods, the percentage of PICU admissions as critical trauma actually increased markedly. So you don't have to worry about it going someplace, right? You have a rich research opportunity. These are the largest pediatric critical trauma services in Southern California. Can we see why data from our PICUs might be informative? We share the science journey, okay? If you just put yourself into service, you're missing an important thing. We use the scientific method, we share it, we stand on one another's shoulders. So that's what ICAN, I thought, was supposed to be about.